Thank you. So my name's Joan McLeod and I'm the Chief Occupational Therapist at Cabrini Health. And at Cabrini Health we have a program for patients with primary brain tumours, and I'm one of the occupational therapists who works in that program. We actually see patients from the acute setting right through to rehabilitation and through to our palliative care service at Paran as well. And we work in a team. So I was just going to talk about the three things that I think help people get back into life. And the first thing I think Ben actually spoke about beautifully, and that was making sure that you surround yourself with a team of people. So that's people such as your family and your friends, but also having a good health team around you as well, a team of health professionals that understand what you're going through. And you may not need them the whole time throughout your journey, but at different times, different people in that team may become important for you. And so it's good to build that network at the beginning so that when you do need those people, they're there to assist you. And if you're not sure how to build that team, talking to your neurologist, coming into a rehabilitation program will help you to form that team as well. I think the second thing is to set some goals for yourself after you've had your surgery and you might have had radiotherapy and chemotherapy. It's important to prioritise, to work out what's important to you and to set some achievable goals so that you can feel that you're kicking some goals. And some people prioritise, so I've had patients that really just worked and then they're diagnosed with a brain tumour, and then they decide to go on that holiday that they've been thinking about for a number of years but actually never got there. So just reprioritising and working out what's important for you. And having something to look forward to I think is really important as well. You've had a really tough time as well as your carers as well, and so having something positive to look forward to I think is important. And the third thing that Ben spoke about as well is taking care of yourself. So making sure that you eat well, getting plenty of rest and exercise. You might find that your concentration's not as good as it was, that you're fatigued, not just from the brain tumour and the surgery, but also from the effects of things like radiation as well, which can have a major effect on your energy levels. And health professionals such as occupational therapists can help you manage your fatigue if you're having difficulty with that as well. So I guess they're my three tips. I'll hand over to Helen.
Yeah, thank you. So I'm Helen Kugel. I'm currently acting as Chief Physiotherapist at Cabrini. My role with people with brain tumours is in the inpatient rehab setting, so often this will be pretty soon after diagnosis and perhaps after their first brain surgery. So it's a pretty fresh sort of time for people, and I guess my tips sort of revolve around this time of gathering information, acceptance and moving forwards. So I think Joe mentioned before that Ben's made a wonderful job of actually probably covering all of our top tips, but we'll persevere nonetheless. So I guess my advice would be in this early phase is don't put your life on hold until you reach your big goals. So in rehabilitation with the team around you, you can really set smaller goals that allow you to participate in life or get back to, I guess, the things that you really find meaningful early on. So don't say, I'm not going to go to that party until I can walk and speak fluently and won't drop a cup in my left hand. Your team can really help you to modify the environment and support you to get back into it as early as possible. And I guess that brings me to my sort of second point, is that you really have to integrate your therapy into your lifestyle. Fatigue is a big problem, and you don't want to spend all of your energy doing a really, really great physio session that then means you have to miss grandma's 90th birthday the next day because you're so exhausted. So you really have to find that balance. and certainly the team around you can help weigh up where you put your energy and how to best manage that. And it's okay if, from a physiotherapy point of view, we flex in and out of your lifestyle depending on your needs. I guess my third tip would be to involve your family and friends early. So as you learn about that tsunami of information that's coming on, and you learn that about your strengths, possibly also your limitations, that they're there on that journey with you, and there's no disparity between expectations, and they can really support you through that early phase from the beginning.
Great, thanks, Helen.
Hi, my name's Cher. I'm a neurologist and neuro-oncologist at the Austin and Epworth hospitals. I think for the big three that I put down is, the first thing I think that's often hardest is to get your head in the right space. You sort of get thrown into this bizarre world of brain tumours and you're trying to work out which way's up. And so I have a phrase that I find, particularly in the low grades, that's useful, is to sort of use the term optimistic realism or realistic optimism. And it's not a switch that you flick and all of a sudden you're there, and it doesn't, you're allowed certainly to have times when you're not feeling so optimistic, but I guess it's sort of a way of thinking about how do I try and get the balance in what I'm trying to do. And then the second thing I think that's important is to try and the more understanding you have of the information that's out there, the easier it is to put things in perspective. And I think trying to get a perspective on things is very important. But it's also important that you don't sort of get so flooded with information that your brain just sort of switches off. So it's my usual phrase that I use with people is, don't try and get your PhD in one night. You probably agree with that too. But that you can take in, and different people will want different sorts of information. So some people will want to understand all the molecular biology and the latest research and that sort of thing, and that's fine, but that's not the first thing you need to do. So it's a matter of, and some people, will not want to have any information. In fact, I remember one patient who didn't even want to know the name of the tumour. She just decided that was all right for her. I mean, it worked out okay. It wasn't an issue of denial, but that's the way she started at the beginning. That's what she could cope with, and she sort of built on from there. So there's not a right or wrong way to do a lot of this stuff, but it's a matter of trying to build it up gradually. And the other thing is that I think that we are seeing sort of research in the area of low-grade gliomas. In fact, there was a recent paper just published a few weeks ago in the New England Journal, and when we're dealing with low-grade gliomas, the thing to keep in mind is that as we're trying to understand how we should do these things with the lower-grade tumours, it takes a long time. It takes a long time to get that information. So these were studies that were started in the mid to late 90s, and we're only getting the results. This paper's only published this year. So because people with lower-grade tumours live much longer, it takes a long time to be able to say, well, something that happened a long time ago, what are the long-term effects? And what was interesting when these studies were first published, the initial studies, it didn't seem to show any benefit, but only when we followed people for a much longer period of time did we see that. So these sorts of things evolve over time, but what's frustrating is that it takes a while. And just coming back to my optimistic point, it reminds me of a story. There were two studies that were presented at ASCO a couple of years ago in the grade 3 tumours, anaplastic tumours, and there was a meeting that was held at the time because there were some studies that were planned that all of a sudden getting turned upside down because of this new data. And all these oncologists and neurologists were discussing this, and what should we do, and do we want to go back to this older chemotherapy? What should we do with this chemotherapy? Anyway, I was sitting next to a guy called Skip Grossman, who's a very well-known elder statesman of neuro-oncology from Johns Hopkins, and he said, you see, neuro-oncologists just don't know when to be happy about good news. So, I think we do need to see that there are some good news stories there. We've still got a lot of things that we need to do better, but that's being worked on, but it takes a while.
Great. Okay. I was going to actually open it to questions, and Ben, you'll be able to address some of those. So does anybody have any questions? I've got a few questions for the panel, so I can probably kick things off while we're thinking. I suppose I talk, so in my role I'm a neuro-oncology a care coordinator at the ONJ, and I speak to a lot of people about fatigue management, and I just, and a part of, I guess, the strategy that I always talk to people about is returning to, like, getting back to beginning to move again and doing some exercise. What, is there any particular strategies that the panel would suggest in terms of getting back to exercise if people don't quite know how to get started?
Yeah, thank you. Thank you. So I can probably talk on that one. Is the microphone working?
Yep.
Yes,
yeah.
good.
Yeah.
So I guess the important thing to remember with getting back to exercise and physical activity is that really it has to be a tailored program for the individual. So it's no good to say, oh, I heard that 20 minutes on the bike will help me walk better or something. So you really need to make a structured program that is tailored to your needs, and then, like I said before, that also meets the needs of your lifestyle. So something that will contribute to your fatigue management, but not then also overdo it. And certainly your team can guide you with that, and hopefully sometimes your carers as well, because we all want to do a little bit better, and think that sometimes more is more, but we really have to pull back sometimes, and know when to turn it down. Often people are very, very keen to exercise, and it does help fatigue management, but just need to find that balance.
Okay, great, thanks. Yep, Ian.
Yeah, my name's Ian. I'm looked after by the amazing people at Olivia Newton-John, including Di and Wigan, but that's not the point. I've got a low-grade tumour, and part of me goes, you beauty, I've got a low-grade tumour. Part of me goes, oh shit, I've got a low-grade tumour, which is, you know, that optimistic realism thing. My question is, well, I don't really know. It's an unanswerable question, but it's just tips that I'm after. I'm going through a battle of fighting financial, insurance people. I want to live the rest of my life the way I want to live it, the way we want to live it, and not be at the hands of their decision. But what sort of time frame, without having a time frame, how do you focus on, do I spend all my money this year or over the next 10 years? Or, it's, as I said, it's unanswerable, but trying to get my head around that lack of time frame thing it's doing my head in.
Yep.
So just some tips there would be great.
Okay.
Yep,
Would you like to
might
take
start. That would be,
great.
I can certainly relate to that. That's almost a daily discussion in our house. And it's very hard. It's about setting small goals and things that you want to do, doing them while you can. But there is no easy answer, I'm afraid, to that.
I think the difficult part from us on the medical side is to be able to look at the patient and say, we can expect X, Y, or Z, because there is this huge variability. I'll give another example. There's a lady who was diagnosed with a low-grade glioma, it must be 15 years ago. She had a biopsy, and I've been following up all that time. The tumour has not changed in that 15 years. And, we've talked about maybe doing another biopsy. Was it really that was the right diagnosis? Was it something else or funny? And we've looked at the pathology again. But if when I had that initial discussion with her, I would have said, no, that's not going to happen. So, we see other people with what looks like low-grade gliomas that progress very rapidly. Now, I think a lot of it's related to the biology. As we understand the biology better, maybe we can tailor it a little bit more. But even within those different groups, we see huge variability. So, while we don't have crystal balls. They don't give them out anymore at medical school. Actually, no, they never did. But, so it does make it hard, and I guess you have to, hope for the best and plan for the worst sort of thing. While it sounds a little trite, you've got to sort of try and get the balance right there, and we've got to be realistic about what's available, what does insurance mean, etc. So it's not really an answer. I don't know that it's solvable, but we've got to sort of try and get that, be realistic about it as well.
will just make a comment that I suppose that what's really difficult, particularly I think with people diagnosed with low-grade tumours, is that there isn't the superannuation insurance system is very tailored towards real specifics about how is this person going to be in 12 months, how is this person going to be in 2 years, and it's the way the system is devised which really hasn't caught up really with the reality of people's experience when they've got a low grade. I'm not sure, that's sort of perhaps more a comment rather than an answer. I know last year we had someone from the Cancer Council talk about their services, and certainly I'd sort of take it on notice that perhaps that's something that we need to do some more special work on. Yeah.
I'm currently dealing with a number of insurances associated with a lot of this sort of stuff. I just don't think there's an empathy or an understanding from their perspective is exactly where the individuals sit in the process and what the eventual outcome is. We all know that it's how long is a piece of string as to how long we're actually going to be still wandering around. But at the end of the day, I think that needs to be looked at fairly closely and brought into a little bit more perspective from their perspective, and decisions made, because the extra stress and strain that goes on within the families, both financially and obviously medically, etc., is just what I call unacceptable behaviour from their perspective. And I would relate that back to the ComSec scenario that Four Corners brought out. We've been paralleling with that with another institution, and again, that's just a complete lack of understanding as to where it all sits.
Yeah, absolutely. Yeah, we've got a question up back here. Yep, Sol.
I've got a question about exercise. I used to work out quite heavily before my diagnosis, going to the gym. But since then, I've been a little bit reluctant to do that. And I was wondering if doing too heavy exercise may increase some of your growth hormones, or like IGF-1 levels, and actually make your state worse. So my question is, currently I'm only doing like a 1 hour walk a day. Is it okay to get back to heavier exercise, or is it just better to do light things from now on?
Yes, that's a very good question. So a lot of people are worried about returning to exercise. I guess the message is that it has to be a graded return, so I can't just say suddenly, yes, go back to running or something like that. So you really have to work with your team to build a program that we can then see your reaction to that exercise, so you won't know straight away if it's impacting you negatively from a fatigue point of view, or if it's actually going to make you stronger and able to perform sort of better throughout your day. But there's no real evidence to suggest that exercise is detrimental to the body. It's more the fatigue that will be the impact.
Just an additional thing about that as well as with I don't think that there's any need to be concerned that exercise is going to cause the tumour to grow, but the other thing where exercise is important, particularly in those on dexamethasone, where you're getting muscle weakness, particularly in the proximal muscles around the hips, getting up out of a chair, that sort of thing. What we find is if the more exercise that you're doing, so if somebody's sitting, is not able to move around and they're on high doses of dexamethasone, the muscle weakness occurs much more quickly and more intensively. So exercising regularly, whether it's walking or whatever it might be, but does definitely help mitigate against that. So if that's possible, but obviously it depends on each person's situation.
Okay. Great. I've got a. Okay. Yes.
Hello. My question is probably most directed at Lawrence and Ben. We have a 22-year-old that was diagnosed when she was 21 with a low-grade glioma, and being at an age where she was in tertiary studies and setting goals for her future and ambitions, where she's really struggling with what you talked about, the optimistic realism and the realistic optimism, and it's something we struggle with in terms of supporting her because she's so unsure. So I suppose it's a bit of a follow-on to Ian's question that I don't know if there's an answer to, but I'm just interested in whether you can tease out that optimistic realism a little further and talk about that a bit more. Thank you.
Well, I mean, I think it's a matter of the way I sort of try and approach it with patients is to say, well, what are the things that are important to you? And that you shouldn't put your life on hold and say, you know, look, I thought about doing X, I'm not going to do that now because that's not realistic. You know, I think it's still reasonable to go ahead because we cannot tell you, you know, that, and particularly in the lower grade setting, I think, you know, you can, you know, still go ahead and do those sorts of things without problems. I mean, the other issue that comes up is, for example, somebody's had a low grade tumour and they want to have a family. Do you say to somebody, you know, in the bad old days, you know, the doctor would say, you can't have a child, that's irresponsible. Obviously we don't do that anymore, that's wrong. But, you know, I think you've got, you can't sort of, you can sit there and put your life on hold and just say, I don't know what's going to happen, I'm not going to do anything. And I don't think that's the right approach. You know, you've got to tailor it to your specific situation, and the more information you can get to get a bit of a clearer idea. But I think you've got to take it, as Ben was saying during his presentation, I think you've got to some degree, live for today. You've got to do that in the context of the realistic aspect of, you know, what's achievable and so on. But you know, this lady that I mentioned the other day, you know, she was a teacher. If she'd said, well, I'm going to put it all away and not do anything, that would have been terrible. And she's gone on to see her children grow up, etc., etc. But so I think we all have uncertainty in life. We all don't know what's going to happen to us tomorrow, and we usually don't like to think about that. And there could be some catastrophic event totally unrelated to anything that could happen. But I think we've got to continue to do what we want to do, and say, yes, there's uncertainty, but these things are important to me. I'm going to keep on doing them.
And I'll just add to that, possibly from a more emotional side, that you know, absolutely you'll have ups and downs as carers of your daughter, but it's fine for if she's feeling down. It's fine to be feeling down for a while. So you've got to be able. It's important to handle both, and be comfortable in both. And that takes a bit of getting used to. That kind of wallowing, I talk about it as being for not for too long, but just for, because these are huge changes in her life. Yeah.
Thank you. Yeah. Can I just hold that thought, Gail? I'll come back to you. I guess I wanted to. Actually, no. Sorry. Go ahead, Gail. I'd love to hear what you had.
I'm going to go into 6 weeks of the radiation and the chemotherapy next week. But what surprised me was my low-grade tumour suddenly moving again or reappearing or whatever it does, because I had actually decided it wasn't coming back anyway. And I don't think it's, listen to me, I don't think it's going to do too much more damage. But at the same time, it's such a pain. I don't feel like I can really organise anything. And I don't understand why it came back as quickly as it did, seeing as it was a 1PQ19 co-deletion. Lawrence, whatever it was called. I'll leave it with you.
Okay, well, let me maybe generalise it a little bit. So this does come to that issue of uncertainty. The issue, I guess, with these particularly with the low-grade tumours, and I'll probably use this example with you, is that I usually sort of, it's a bit like in the old westerns where the guy says, take another step and I'll live from lead, and then the guy moves forward, you know, 0.5 of a millimetre. Are you going to pull the trigger? You probably won't. And what we often see with the low-grade tumours is that you compare scan to scan, you don't see much difference, and you keep doing that, but then you go back a few years and you say, well, this thing's actually moved more than I realised. And so, but at some point it'll get to the point where you say, now's the time we need to intervene. So it seems like there's a big sudden change, but it's just, this thing's, you know, it's moved very slowly, but just got to the point where you say, look, we should do something a bit more definitive. So that's often the situation with the low grades, that we, people get a bit of a shock all of a sudden and say, well, I thought it's all behaving itself, but it often just gets to the point where you say, okay, now now's the time to pull the trigger.
Okay. Lynn, at the back. Oh, sorry. While you're doing that, I was actually just going to ask, I guess it sort of follows on a little bit from what Ian was saying, and also the planning for the future, Joe. But how do you talk to people about if? I suppose I've come across situations where people have had really very full-on jobs before they were diagnosed, and whilst they're doing pretty okay and wanting to get back into doing something, perhaps going back to what they were previously doing is out of the realms of possibility. How do you sort of talk with people about that sort of element, return to work?
Yeah, thanks very much. I think returning to work is something that you should generally seek some help with from a health professional, and you need to consider the sort of work that you're going back to. So are you going back to a factory job where you need to be operating machinery, and is there some safety issues with that if your concentration or your fatigue levels are affecting your concentration, so you're not quite as you were before? Do you need to do a job that's up high, so you're on ladders and things like that, and again, if your balance has been affected, is that going to make it difficult for you? But apart from that side of things, also just to consider the demands, particularly cognitive and physical demands of the job, and how your surgery or brain tumour or treatment that you've had has affected your ability to concentrate, to attend to information, to problem solve, to plan, to organise yourself. And sometimes you may not be, the person may not be fully aware of their function in that regard, and particularly if it's more subtle, but your family or carers may be more aware of that. And so it's probably, if you're going back to a demanding sort of job, it's probably good to be assessed by somebody like a neuropsychologist who can really have a look at your strengths in your thinking skills or cognitive function, and also look at the areas where you're having more difficulty, and then to talk to that person or to an occupational therapist and look at compensatory strategies, perhaps to help you liaise with your employer as well, because maybe you can get back to your job but you need to do it more gradually. Maybe you can't go back to working full time, and particularly at the beginning. Maybe you need a quiet environment that's free from distractions, where before you've been able to work in a really noisy environment. And these days a lot of office jobs are very open plan and it's quite noisy. There's lots going on around you, and maybe you're having more difficulty now filtering out all of that background noise. Some employers are quite flexible these days and will look at people doing some work from home, and that can work positively as well, because I know I've had patients where just the effort of getting to work has made them too fatigued to actually do the job when they get there. So if they can do some work from home or do a little bit of both, working from home and going into work, that can be beneficial. Obviously there's social benefits for going back to work and seeing your colleagues and getting back into normal life, having a bit of a laugh, talking to people, that's all beneficial as well. So a little bit of balance. So I guess it's working with your team to look at an individual sort of return to work program for you. And if you're not able to go back to the position that you were doing, looking at what alternative roles you might be able to do in the organisation that you are with, or looking at something completely different as well.
Okay, Lynn, question.
Oh, hi. I just had a question. I've been living with GBM for 7 years, and always my scans are compared to the previous scan. So should I be asking for my scans to be compared to the scan from 7 years ago?
Look, I do find it helpful often to go back at least 6 months or 12 months sometimes, intermittently. Usually the good radiologists will do that, and they'll sort of follow along and look for any sort of subtle changes. But yeah, it doesn't hurt every now and again just to compare it. I mean, it's sometimes the art of looking at an MRI is often quite difficult because you get changes related to the radiotherapy as well as other things that can sort of affect it. So, yeah, it's all, you know, I find it useful even in the higher grade tumours too.
Okay, oh, here's another one I prepared earlier. I guess picking up from what you said, Joe, and just in terms of people being able to have access to and finding out what their cognitive strengths are, because really, I suppose, in returning to a previous role or even getting involved in a new something, whether it's a study or a slightly different activity that you're doing, in order to identify that it's great to have a neuropsychology, how do people access, what's the best way for people to access neuropsychology, do you think?
So if you're, does that work?
Yeah, it's good.
Yeah, if you're with a healthcare team or perhaps going through a rehabilitation centre, there'll be neuropsychologists that you can access. So I would suggest speaking to your doctor. Probably the first person, or any member of your healthcare team should be able to direct you to a neuropsychologist. Some neuropsychologists work as part of hospital systems and others work privately, so it really depends on your area and your healthcare organisation.
So, yeah, that's great. So it'd be fair to say that most of the major public health networks would have neuropsychology team. There can be a fairly long wait for assessment, but there's also a number of private neuropsychologists working around the areas too. Did you have any other comments for that, Lawrence?
Well, just something that comes to mind, it's a little bit off topic, but I think probably worthwhile mentioning is one of the issues that sometimes comes up is that we get a letter from a lawyer saying, oh, this person changed their will at such and such a time. I just want you to confirm that they were competent to change their will at that time. And it drives me nuts because it's totally unfair. It's impossible to answer that question. So I think it is important if there are issues with, wills and power of attorney, all this sort of stuff, that's done properly. And if if you're doing that you make sure that you check with somebody. You get some sort of confirmation and it's documented somewhere that yes, this person was competent. And look, in most circumstances, in most families, it's not a problem, but there are always problems where there are issues and so on. And for some reason, the lawyers don't seem to tweet that this could be an issue. And I think it saves a lot of angst that at least you ask the question and it gets documented somewhere. And that if there is an issue, then going to see a neuropsychologist or whatever, then they can do a relatively quick screen and say, yes, this person's competent or they're not, and then that solves the issue. But sometimes it can drag on and cause a lot of unnecessary angst. So I just put that in as, hopefully there shouldn't be any familial issues, but, as people say, you can pick your friends, you can pick your nose, but you can't pick your family. So it's important to have these things sort of done properly to avoid problems down the road.
Yep, got a question? Wendy? Yep.
Thank you. Just another one for Ben. I'm interested in changes you felt with regard to your studies and strategies that you might have implemented to cope with fatigue and concentration changes and processing changes and things like that.
Sure, yeah. So a PhD it's treated like a full-time job when you're working on a scholarship. And when I went back, one of the first things I did was contacted the disability service at the university because it's a cognitive disability, and I had similar things like neuropsych assessments and things, and they made adjustments. So one of the like many possibly in this room, I can't handle lots of noise around me, so busy restaurants and things. untold. It's, as you get older, that becomes more common. But yeah. So one of the adjustments that was made is that I've got a little room just very quiet that I can study in, and obviously my supervisor knows, and so they're able to, I take leave if I need it. I'm not part-time, but I'm full-time, but taking leave as I need to, just to manage what is a health condition. So it's treated like a chronic health condition. Yeah.
Yeah, I think I guess also in a university environment or a school environment, particularly teenagers who are gearing up towards VCE and the more important years at school, you can apply for special consideration as well. And at university, again, if you need longer to do exams or your hand function's not as good and so you can't write as quickly as you used to, you can apply to get longer periods of time, to have breaks if you need to, that sort of thing to help. I think also it is worth seeing somebody like an occupational therapist. We work a lot with people who need to get back into activities that require a lot of cognitive demand, and having somebody sort of step you through that, give you a graded sort of progression back into those activities, and helping you to compensate for some of the difficulties that you're having is important, and those programs can be tailored to the individual person as well.
And I would highly recommend that. I've had an occupational therapist as part of my rehab. So.
And I think Ben hit on a really good point, that is a low-grade tumour or living with a brain tumour for an extended period of time really is a chronic illness, and being able to access some of those supports that perhaps are more traditionally accessed by people perhaps in wheelchairs or with a very evident physical disability, to ensure that you can access some of those things that are going to be able to help and support you and help you modify things in a way that you can still achieve things, but in a more graded or modified way. Would that be fair? Yep. Okay. Yeah, question here, the front. Just doing a great job, Marcia. Yep.
Question for the occupational therapist. Is occupational therapy only to do with physical disabilities following tumour, or can you help also with the sort of connecting up the neural pathways again?
It's a very good question, and a lot of people don't fully understand what an occupational therapist does until they're working with one. But occupational therapists really look at people's return to all their everyday activities and look at what's stopping people from returning to their activities. So whether that's physical or whether it's cognitive or psychosocial, we actually look at that from a very holistic point of view. So, we do a lot of treatment with people, particularly with upper limb physical problems, and we also do look at people, who have lots of cognitive problems as well, and difficulties with their thinking skills. So the whole range, yeah.
Otherwise, Lawrence will start telling jokes. Come on.
My kids would say no.
That's right. I know, I won't leave. No, you don't want to go there.
I have a question more related to diet. My sister was diagnosed last year, and just looking for some tips really as a carer, like if someone becomes quite obsessive with their food intake, how do you kind of negotiate that minefield of saying, hey, maybe this is a bit detrimental, like that kind of thing?
Okay. I can do a bit of a caveat over the top. I suppose something I observe from working with people is that there's a lot of this illness that you can't control. And so I think things like diet and nutritional intake is something that people can focus very strongly on, because it's a sense of being able to control what's happening. So that's sort of my feeling. So I try and, I suppose, talk through that and get some balance, but I'd like to open it to the panel. Yeah.
Certainly, diet's a big thing, and I agree it is something we can control. So it's something I would just. It's really important for me to kind of think about what goes into your body and onto your skin, but not to go too overboard. And there are moments, of course, where I go overboard, and it's up to my family and my partner to kind of pull me back into line a bit. Yeah, I won't say any more than that, I don't think.
Yeah, so I guess there are a couple of issues. So, I mean, often it can be a couple of reasons for the, and is it more that she's eating way too much? Is that part of the problem?
From my opinion, I'd say less, not enough.
Not enough. Okay, all right. So, I mean, the issues around food are sometimes with the steroids can stimulate appetite, and you tend to go for the sweet and fatty foods, and so you can put on a lot of weight quite rapidly, and then it's very hard to get off, and that with the muscle weakness causes more problems. So I think it's important to recognise that early and just sort of to try and focus on, okay, and not to say that you have to be, you can't have anything sweet or you can't have something, but that it's sort of in a balance. I mean, some people also sort of get focused on food in terms of, you know, if I have too much sugar, if I have any sugar, I'm going to feed the tumour, and I think that's also going too far the other direction. So I think it's a matter of trying to get that balance right and saying, yes, I want to eat healthily, I want to, you know, look after myself, but anything that goes to an extreme often tends to cause more problems. So I think it's also an issue, I think, of just to encourage, if you become a nudge, you tend to go too far the other way. Certain, you know, if you've had radiotherapy in certain parts of the brain, it can affect your appetite so you don't feel like eating. And that's not uncommon after radiotherapy to the temporal lobes in particular. People lose their appetite, so that can be an issue. It usually does improve. It's sometimes helpful to get a dietitian involved who can say, well, look, you know, have these are some nutritional supplements that'll help you get the nutrition you need even if you don't feel like eating. So there are some ways to deal with it, but as Don was saying, I think also we need to know where it's important to sort of push when we're trying to help people, but also to sort of say, well, okay, well, this is manageable, this is not manageable, it's maybe not ideal, but we can cope with it.
Okay. So I suppose thinking about, you know, your nutritional intake as it's fuel for your body, so depending on what your body's going through, it needs to be sustainable. I think it's really important that people eat very well, but it needs to be something that's very sustainable, and that can ensure that your body can cope with the chemotherapy you're taking, the other medications, that it's actually, yeah, it's a balance as part of the picture. There's a question next door.
Could I just add this? We're here for the same person who's not here, but this is under the guidance of an alternate therapist, and it's what I guess the books suggest is too much of an extreme diet that she's embraced with a belief.
Okay.
Yeah, I mean, I think, well, it's very hard to answer those because, you know, I mean, I guess what happens is we're all looking for that magic answer, which we'd love to have, and part of the problem sometimes with these alternative therapies, and I'm not saying anything against this particular person, whoever it might be, I don't know, but, you know, there was a group in Adelaide I remember hearing about that sort of pushed a particular diet, and if the tumour came back, it meant it was all your fault because you hadn't been eating properly. You know, that was how they approached people in that situation, and that's obviously just horrendous, horrible. I don't know if it's possible to engage with that particular person yourselves and say, do you understand what's going on here? And maybe through your treating team, you could, you know, get her to see a dietitian and have a discussion with the dietitian about what's happening. I don't have an easy answer to that. You know, we can always make recommendations and say this is the way we would look at things, and people are autonomous and will make their own decisions of what they want to do. But I think maybe the other way to go at it is to say, well, what is it? Why did you particularly pick this diet? What is it about it that you think is so good? Why this one and not something else? Or how about we have a bit of a wider think and have a chat with the dietitian? I don't know if that'll help, but maybe one approach.
Can I just make the comment as a carer?
Yeah.
Hannah might have something to add to it. But it's one of the challenges we have with a young adult in our care that we're caring for, and she's old enough now as a young adult to make her decisions, and we talk about it an awful lot as a family, but ultimately they're her decisions, and sometimes we don't like them, and we sort of have to respect them, and we hope that they're right because they're not the decision we'd have made. And I think I'm hearing that a bit from you, and I don't know if the panel wants to add something to that, but we certainly feel it as one of our challenges, and probably we don't have too many of those challenges, but it is one where she makes the decisions and we don't, what we live with and what we have to accept. So it's tough.
I mean, it's tricky from a personal perspective. For me, I've certainly made a number of decisions in my life that haven't been good decisions. So, I mean, I think we've all sort of been that, and I think part of being an adult is actually having the right to make not so good decisions as well as good decisions. I mean, unfortunately, the stakes are very high in something like this, but I don't know whether anyone else has any comments. Yep.
Yeah, so I guess one of my top 3 tips was to involve your family and friends early, so you're sharing that experience and gathering that information together. So I guess it's important to then know when to step back and respect the person's space, so that they then don't start cutting you out of that information circle and that support circle. So it's very, very difficult, of course, when people are making decisions you perhaps don't agree with. But I would, I guess I'd foster open communication, and then, of course, it is down to themselves in the end.
Okay, well, we've hit that time where I'm hoping that it's been a useful opportunity to just ask questions. And thank you very much to all our panellists for contributing.